But just for the listeners of this podcast, I'm going to clue you into the dirty secret of cardiology. Don't tell anybody. But the calcified plaques are not the ones that rupture and cause heart attack. And this is why I think when people have a 0 calcium score, I'm still afraid. Because non-calcified plaque, or what we call soft plaque, that has not yet built those walls around the prisoner, so to speak. So you have all those enzymes that are trying to digest the walls. Those are the 20, 30, 40, 50% lesions that don't cause symptoms, that don't cause chest pain or shortness of breath or toothache or whatever symptom might be. Those are the ones that rupture, right? So that's where a calcium score alone, I mean, don't get me wrong, a 0 calcium score is great, but you need to always check it with markers of vascular inflammation, because it's a very different thing to have a 0 calcium score with normal markers of vascular inflammation than to have a 0 calcium score with sky high markers of vascular inflammation. Because if you have those sky high markers, we've got some work to do.
Well, hello there. I'm Dr. Kate Henry, your host for today. And today we've got an amazing guest for you, Dr. Sanjay Bhojraj. Now, Dr. Bhojraj is one of our educators at Rupa Health. He teaches the cardiometabolic section of our clinical decision guides for functional medicine lab testing bootcamp that we do in partnership with the Institute for Functional Medicine. It's happening in a few weeks. And so if you want to learn more from Dr. B after listening today, make sure you go sign up for that if you're a practitioner. But today we're going to dive into a couple really important things. What are the essential tests that you have to ask your doctor for if you're really trying to figure out your cardiovascular risk? Why does the calcium score not give you the full story about the plaque in your arteries and your risk for a heart attack? We're going to talk about advanced lipids and ApoB, LPA, you name it. We're going to dive into it. And Dr. B is going to make you laugh. He's one of my favorite people to talk to about cardiovascular health because he has such a cool way of describing things that really helps you remember them. More importantly, Dr. B is someone I trust and who's helped some of my family members over the years. He's a wonderful asset, and you can enroll in his clinic, Well 12 Health, if you're looking to get the most advanced care available in cardiovascular medicine and stay healthy as long as you can. Dr. Sanjay Bhojraj, welcome to the Root Cause Medicine podcast.
Dr. Kate, thank you so much. It's so great to be here, and thank you for having me on the podcast.
You're one of our favorites at Rupa. I met you through our IFM bootcamp the first time and just watched you captivate an audience. And I learned your story about being an interventional cardiologist for 20 years and now running a functional medicine practice. And I'm so thrilled to have you here to teach us about cardiology today and metabolic health. But before we dive in, tell us a little bit about who you are and what you stand for.
Sure. So it's amazing that I was able to make lipids cool enough to grab your attention. So I'm glad I was able to do that. But yeah, I mean, just like you said, so I've been an interventional cardiologist for about 20 years or so and reached that point in my career where I was doing everything. So for those of you who don't know what an interventional cardiologist, there's a regular cardiologist who's following blood pressure, cholesterol, running stress tests and things. And I was the doctor that actually did cardiovascular procedures. So I did coronary angiograms, which is where we go in and take pictures of the arteries. And I was deploying stents, which are those little springs that you inflate into the artery walls to hold it open. I was doing heart valve procedures, something called transcatheter aortic valve replacement, where rather than doing open surgery, I was able to go in through the arteries in the legs and actually deploy a new heart valve in patients that couldn't get surgery or didn't want to have surgery. So I was doing some pretty high level cardiovascular procedures. But something always just didn't sit well with me was, why did we get here in the first place, right? What are the 10,000 steps before that 2 a.m. heart attack that we zigged when we should have zagged, right? That would not have led us here. And so in quite a backwards way, and we can talk about that story here in a little bit, I fell into functional medicine, and it was exactly what I was looking for. I think that we all go to med school and we all have the same personal statement, right? I want to help people, right? In some way, shape, or form. I want to create my own mark on this world. And I thought I did a pretty good job of it with procedures, but it never sat with me that people would come and be like, Doc, I want to get off meds. I want to do something healthy. What do you got for me? And in med school, our nutrition education is embarrassing, right? We get I think I maybe had like 45 minutes of medical instruction in nutrition in the 7+ years that it took me to become a cardiologist. And that's just not enough. And that's really where I fell in love with functional medicine, was really focusing on the nutrition, the nutritional biochemistry, just making sense of how these micronutrients, these macronutrients, these phytochemicals, all these things that we eat, how do they work inside the body and how can they optimize health? And I think that there's nowhere more important to this than cardiometabolics, because as we look at the statistics, And whoever's watching this podcast, obviously we're smart folks, but the numbers are staggering. I read an article actually this morning that in England, for the first time, we've seen an uptick 3 years in a row of greater cardiovascular incidents. So more heart attacks, more strokes for the first time in 15 or 20 years. Metabolic diseases, particularly insulin resistance and diabetes, are on the rise, right? 1 in 3 people in the United States over the age of 25 has either insulin resistance, diabetes, metabolic syndrome. And as a cardiologist, this scares me because when we look at blood vessels, right? And I inherited patients from the 70s and 80s in the early part of my career. At that point, it was really the smoking that was the big deal. And I think we've done a great job from a public health standpoint in reducing smoking. But we see even worse pathology when we look inside the vessels of diabetics and long term diabetics. Whereas with smokers, when you look at a coronary artery, you'll see a discrete lesion. So a nice little 90% blockage that I can put a stent in and high five, and we're great in 20 minutes. With diabetes and insulin resistance, you really see this diffuse disease. So you take a long artery and there's just disease everywhere. And that's really scary because that doesn't leave us many options to fix, right? So getting back to my functional medicine epiphany, so I realized, you know what? So much of this is diet, so much of this is lifestyle. Somebody in the cardiology space needs to learn more about this and preach the gospel of functional medicine. And that's kind of where I find myself.
I love it. I'm curious actually, like, was there a moment or a series of moments in a row that made you kind of choose to go down this path?
Well, I mean, you have a lot of wake up calls, but the one that really shook me, well, two instances that shook me. But number one, the first one was my very first patient that I had at my job as a heart attack. She's still alive. Wonderful lady, fantastic. She looks like she would be like one of the characters on Sex and the City. Just a fabulous woman. Came into another outside hospital, not my institution, said that she was just kind of feeling off, had some chest pain. And they kind of looked at her and said, it's probably just anxiety. No big deal. Go home. And literally they told her, have a glass of red wine. So let's have that, a whole other discussion is women and heart disease. But they said, have a glass of wine. It's probably anxiety. Go sleep it off. She knew something wasn't right. So she ended up coming to my hospital and her husband drove her, which for those of you in the audience, if you're thinking you might have a heart issue, never have a family member drive you, right? Always by ambulance. So she walked across the threshold of our emergency department and had a cardiac arrest right there, VTVF arrest. So chest compression, shocks, all that stuff that you see on TV. I brought her to the cardiac cath lab. She had 100% blockage of her left anterior descending artery, what we call the LAD. Opened it up. She did great, right? 10 years later, she sees me in follow-up. And I'm like, oh my gosh, for all of us as practitioners, there's certain patients when you see them on your schedule for the day, you're like, oh, I can't wait to catch up with that person. So I saw her and did the math and realized that when she had her heart attack, she was actually 3 years younger than I was at that time, right? So meaning that she had her heart attack at 42, 10 years ago. I was 32, and now I was 35 or whatever. And now I'm seeing her, I'm 45, but she had her heart attack when she was 42. And that kind of gave me a moment of pause, right? To take my health seriously. And then that led me then to see my own doctor, and I got my labs done for the first time because we all know doctors are the worst patients, right? Got my labs done and it was a hot mess. It was like a dumpster fire. Insulin resistant, liver enzymes off, my cholesterol was horrible. It's all this genetic stuff being South Asian that I knew that was going to hit, but it all hit the fan at once. My blood pressure was crazy. This was in the middle of COVID. So, eating like garbage, not exercising, not sleeping, stressed out all the time, watching the news, the world is going to end. People are storming the Capitol, Australian wildfires. All these things were happening. And I was stressed out all the time. And my doctor said, Sanjay, got all these things going on. Let's get you on these 4 medicines. And, I mean, for someone who's like a professional drug pusher, medicine pusher, I was like, whoa, wow. We go from 0 to 4. That seems like a lot. Let me kind of do my own thing. And I got the doctor eye roll, which unfortunately a lot of patients get like, all right, we're going to try diet and lifestyle. Let's see what happens. But that really kind of steeled my resolve. And I kind of went back to the functional medicine training and really kind of focused myself. And so within 8 weeks or so, made significant lifestyle diet changes just through diet, lifestyle alone, dropped 25 pounds. Of course, I'm a data nerd. So I actually had a DEXA scan done pre and post to kind of check my visceral fat. My visceral fat went down by 60%. And as this audience knows, that visceral fat is the fat that is inflammatory, that gives you kind of these alterations and like sex hormone binding globulin and leptin resistance, contributes to insulin resistance and all that stuff. And really kind of, I credit it with really saving me from having a heart attack, at age 50, right? And so now I want to do that for everybody, right? Let's heal everybody with the heart. And yeah, so that's kind of my functional medicine story.
That's awesome. And since then, you've founded Well 12. And I'm curious if you could just like, I want to get into that a lot at the end, but I want you to mention it now because it seems like you've taken all the research and all your clinical experience and packaged it into a program that's designed to help this work for everyone fast. Tell us about that.
Yeah, so Well 12 is my program. So www.well12.health is the website. So the program is really a very simple program, but you have to do it to do it, right? And one of the things that I love in medicine is coming up with nickel solutions to $1 million problems, right? So we have these amazing antibodies against specific interleukins and this, that, and the other. But hey, how about we just learn how to sleep? How about we just learn how to chill out, how to breathe, how deep breathing affects us? Learn what are the proper foods to eat, get garbage out of your diet, and health naturally follows. So we can spend some time towards the end, but I've been doing this now for over a year, over 100 patients or clients, I guess I have to call them now. And the benefits that I've seen from this functional medicine approach, from this anti-inflammatory diet, from just giving people a structure and a framework to follow, it's changed my life. And so I'm just excited about all the good that we can bring to the world through functional medicine and just through teaching people how to approach life correctly.
It's so great. And I love that you're making it so doable for people because you're so right. We all hear this stuff, but it's being able to do it every day long enough to make a difference. That's really the key. And I feel like you have some great sayings and tips and tricks and tools to help people really transform, and it clearly worked for you.
I needed to preface this interview by I have a ton of bad 80s movies references and dad jokes. And those definitely kind of creep into the Well 12 program as well. So if you have to Google anything that I asked, sorry about that. I can explain it real time.
We love it. Give us all the jokes. It makes you a captivating speaker, right? So, what I want you to talk about next, because I think some people might have tuned out if they are thinking what I've heard sometimes in practice, which is, well, my parents didn't have a heart attack. There's no real like heart disease risk in my family. So this isn't something I need to worry about. And then on the other hand, we have people we've all known who seem super healthy. They're running all the time, they're eating all the right things, and they end up with a heart attack. And so, how would you know if you're someone who is at risk for heart disease?
A lot of times the outsides don't match the insides, right? So getting back to that woman that I was talking about, my first heart attack patient, on the outside she was not overweight, looked great. She did Pilates a couple of times a week. She smoked, oddly enough, but you really have to know your risks, right? I do a little bit of longevity medicine. And the first thing people ask, oh, doc, what supplement should I be on? Should I be jumping into ice water and then jumping into sauna and all this stuff? And I say the first part of longevity is get your labs checked, right? Like know what's going on with yourself. Everyone wants to be on NAD and they ask me about metformin and should I find rapamycin and kind of all of these highfalutin things. But hey, let's start out with the simple things, right? So let's make sure our blood pressure is under control. Let's look at our body composition, right? Because weight is an imperfect measure of health, right? So look at your body comp, look at your labs, make sure that we know what's going on the inside because what our parents didn't have that we have, I think a lot more of are chemical exposures, right? And so when we look at that environmental toxicities that we have, the BPA and PFAS and PFOS and all those kind of chemicals and all the things that we know and all the things that we don't know, we are not the same as our parents were. Right. And if you think about it, my parents, probably not my parents, but maybe my grandparents, full fat butter, all the things that now we think they shouldn't eat, but they seem to do pretty okay. Right. So, the first thing to do is check your numbers. And this is where I think that conventional cardiology, at least, is a little bit lacking because now we have so much better data, right? We've got advanced lipid panels. We can look at oxidized LDL. You can look at glycosylated LDL. You can look at markers of vascular inflammation. And the cardiology community in general just isn't there yet. I remember when I was still practicing in my group practice and I was talking to a patient about their LDLP, right? LDL particle number, which is not something that most cardiologists deal with. We deal with LDLC, which is LDL concentration. And the difference there being that if you have a bunch of small particle LDLs, which are the more atherogenic, that can hide in an LDLC. And I was mentioning this to one of my partners, and he just looked at me like I was crazy, like I was from Mars, because that was just not part of the clinical practice. And cardiologists, just like really any subspecialty, right? We're all kind of almost frozen in time with our training, right? Maybe we do some maintenance and certification work, study for your board exam every 10 years, whatever it is, but you're kind of a snapshot of whenever your medical training era was. And I think that's where doctors who are functionally minded really excel, because we're trying to stay with the cutting edge. We're trying to stay at the vanguard of medicine, in that where biochemistry, basic science, and clinical medicine meet. That's kind of where I really see the role of functional medicine. So getting back to lab markers, so ask for advanced lipid panels, ask for markers of vascular inflammation. Another one that I love right now is urine microalbumin, right? What is urine microalbumin? Well, we all know about endothelial dysfunction and the disruption of the glycocalyx, and how that's an early marker of vascular disease. Well, one of the most vascularized territories you have in your body is actually in your kidney. And so if you're starting to see early leaking of albumin, these microalbumins, then we see that there's some endothelial disruption in there. And believe it or not, I was at a conference just this weekend where an actual MD, for the first time I've ever in all the conferences I've been to, referenced the glycocalyx, which to the functional medicine community has been something that we've been talking about for a few years. So again, I think that the functional community is really at the leading edge of clinical medicine a lot of times. And it's just this inertia from the conventional docs that they eventually get there, but it takes some time. So that's where people who are watching the podcast, patients who are watching the podcast, that's really where you have to advocate for yourselves. And if you can't find a doc that will do it, reach out to Rupa, reach out to me. We will help facilitate, because our goal, I'm just speaking for Rupa here, but I think I can say this. Our goal is just to make people better, right? And we don't want you to die. So let's do the right work. Let's get the right information, and let's help you live longer.
I love it. So I want you to go through 2 things, actually 3. I was taking notes as you were talking.
Uh-oh. You're going to hold me to something I said? Oh, man. Yep.
Endothelial. The doctors who are listening may know what that means, but some people don't. So I want you to explain that, and then I want to take a deep dive into 2 things next that are gonna help people refine that list of labs you talked about and know which ones they should get. But let's start with the endothelium. What is that?
Right. So imagine your artery, right? We're looking at the artery, and it's a tube, right? And there's three layers on the tube. That's essentially the buildup of, or that's the makeup of an artery. So you're the outside, called the adventitia, the middle part, which is called the media, and then the inside layer, which is called the intima, right? And then inside that intima, think of a layer of shag carpeting, right? I don't know if you're old enough, Dr. Kate, to remember what shag carpeting was, but it looked amazing. It was brown, tan, rust, and those were the four colors that at some point in the 70s and early 80s made sense for someone to put together in a carpet. But that's the layer on the inside of what your blood vessel looks like, is you have the shag carpeting called the endothelium, which is a single cell thick layer of cells. And then on top of that, you have a few microns of this glycocalyx, which is a matrix of carbohydrates, of sugars actually, that helps signal intracellularly into the endothelium what's going on. It's almost like a weather antenna that sticks out there. So when we talk about endothelial function, right, at one point in time, we thought this is just a very passive, just a bunch of cells, nothing really happens. But what we've learned over the years is that the endothelium is actually quite active, secreting growth factors, secreting chemoattractants for white blood cells and red blood cells and platelets and all of these different components of our body, and secretes nitric oxide, which is a vasodilator. And as we get older, right, our ability to secrete or to create, synthesize nitric oxide gets worse. And so that leads to the quote unquote hardening of arteries and hypertension. So the endothelium is this very alive layer. I almost think of it like a coral reef layer on the inside of the blood vessels that we have to optimize to get true vascular health. And when it gets disrupted, then when you see tears in there, just like in shag carpeting in the high trafficked areas, you see tears, you can get tears. And that's where these oxidized LDL particles, the bad cholesterol, the damaged bad cholesterol particles can translocate into the walls, lead to plaque. Enough of that plaque builds up and then digests the vessel wall, and it ruptures. And that's what causes a heart attack. That's the pathophysiology behind a heart attack or a stroke, depending on which, the head and neck territory or the heart territory. So the endothelium is like your first line of defense against vascular disease. Does that make sense? I hope that makes sense.
That makes perfect sense. It's funny, I think of endothelial dysfunction as being similar to leaky gut. People think about leaky gut and they kind of get it. And they're like, "Okay, yeah, I've heard of that." And I'm like, "It's leaky gut in your arteries."
It's like leaky vessel. Yeah, exactly right. I like the shag carpeting reference, but leaky vessel works too.
Let's throw all the references in.
We'll just get a mark that.
So I want to go through your list of biomarkers that you want everyone to make sure that they get, the list of labs. And you actually teach practitioners this in our Institute for Functional Medicine bootcamp, which I'm so thankful. But before we get into the big list that everybody needs to bring to their doctor, let's back up and talk about diagnoses. So, if someone's listening, what are some things they might have already been diagnosed with that should raise their interests right now that they should really be paying attention? And some things I'm thinking about are like if they've been told they have fatty liver, if they've been told they're insulin resistant or have type 2 diabetes, if they have hypertension, like how do you counsel people to kind of say, "Hey, if you've got these, you really need to pay attention to your metabolic and cardiovascular health."
So yeah, so before we even get into diagnosis, I like to talk about kind of clinical scenarios, right? So the first thing is when you're in the shower, take a look down. If you can see your toes, you're great. If you can't see your toes and you got a big kind of gut protruding, you're probably at risk for metabolic disease, right? So that's kind of a something to think about.
And why is that, Dr. Sanjay? Before we go on, like, people might be thinking, "What the heck?"
And that's a preponderance of visceral fat, right? So if you have that kind of central adiposity, it's not so much the subcutaneous, the muffin top stuff that we get worried about, that pinchable kind of soft fat, but it's that fat inside the abdomen that leads to those metabolic derangements, the inflammation, the insulin resistance, leptin resistance, and so that's the real kind of sinister stuff that we need to address sooner rather than later. Another one that I talk about is fatigue. So I have a lot of people that just tell me, you know what, I'm just tired all the time. I wake up and I'm tired. I have to take a nap at night or in the middle of the day. One of the clients in my metabolic program kind of later on confessed to me that he would sneak out to his car and take an hour nap in the middle of the day because he was just so tired, and that nap kind of went away. And what I kind of think of that as mitochondrial disruption. I feel like, we are probably not giving our mitochondria the nutrition that it needs to function correctly to synthesize the ATP to create energy. So fatigue, shortness of breath, disproportionate shortness of breath to your degree of activity. Just that brain fog is another one that I think a lot of people kind of experience. Just, I need to remember, why aren't things coming back the way that they should? So those are some of the clinical scenarios. When we look at labs, right? I think number one, always start with age appropriate labs because and testing. Again, getting my longevity hat on, simple things are simple. So test your electrolytes, get your kidney function checked, your liver function checked. We'll talk about fatty liver in a moment, but get your liver function checked, get your blood counts drawn, right? Let's look at your mean corpuscular volume and look for vitamin deficiencies. Let's see your trend in platelets over time to see if maybe that's an inflammatory marker for you. Let's look at your white blood cells and see, what is that nutritional status that your white blood cells may be indicating that is going on, because high white blood cells are bad, low white blood cells might not be normal either, right? And then as we get into more kind of metabolic markers, certainly a lipid profile. And if you don't have advanced lipids available, just get a basic lipid profile, which is your total cholesterol, your LDL, the bad cholesterol, your HDL, which I now term the less bad cholesterol, and then your triglycerides, right, which are a marker of kind of carbohydrate and fat content in your blood. So those are the basics. And then, another add-on, if you don't have access to an advanced lipid panel, that you can do at most commercial labs is an apolipoprotein B, also called an ApoB, which I like because it's relatively inexpensive, very available even through the big box labs if you don't have access. But Rupa has really kind of democratized that, so you should have access anywhere you are. But it's indicative of the atherogenic lipid particles, right? The bad cholesterol particles. That's apolipoprotein B is like a patch that it wears on its chest to tell you that I'm a bad player, right? Glycosylated hemoglobin A1C, I think is still an important marker, imperfect though it is, because it's not giving us a real kind of understanding of the acute glucose effects, right? It's just kind of an average over 120 days or so, because that's the span of time of a red blood cell, but that's a marker that I like. I mentioned urine microalbumin, which is or urine creatinine, one of the UACR, or urine microalbumin, one or the other, are both in the proper hands good markers of renal function and kind of impending renal dysfunction as well, as we talk about the endothelial disruption. And I think it's something that we're going to hear of more and more in the next few years as a marker of cardiovascular risk. So those are kind of the top, kind of run with those from a cardiometabolic standpoint.
I love it. So CBC, CMP,
See, so CBC, CMP, your regular lipids, your hopefully advanced lipids, and then hemoglobin A1C and urine microalbumin.
Love it, and add on ApoB, guys at home who are writing this down kinda next to your lipid panel, because if you're seeing a person who's not a functional medicine doctor, chances are when you say, "Can you check my lipids?" They're gonna run what's called like a standard lipid panel, right? The cholesterol. They might not add some of the extra things that Dr. B talked about.
And by the way, it's absolutely fine to ask. This is your life, right? So ask for the labs that you want. If they're taking blood, just say, "This is what I want." Like, don't feel bad about it.
Yeah, and I love that you said that. As a cardiologist, it's so interesting how many people tell me they're afraid to ask their doctor to order labs.
Yeah, well, I mean, I can see it, right? But as a doc, right, as a healer, I always want you to feel comfortable, right? And if you don't feel comfortable asking me a simple question like that, then I don't care what happens. This is not a therapeutic relationship, right? So if you don't have that vibe with your doctor, find someone that you vibe with. I tell my patients, you got to feel like you could have a beer with your doctor. Like we're supposed to be like your buddies. You know what I mean? Like I just have this really weird skill set and knowledge set, but other than that, like we're just people, right? And you're gonna respond so much better to someone that you trust and someone that you like to hang out with and someone that you always feel like, it's like your high school principal and you have to be on your best behavior, right? That's not what this should be about.
That's a brilliant piece of advice, and I think if your primary care doctor is not that for you and you like your primary care doc, you could always add another practitioner alongside your primary care doc that you can have these kind of conversations with. Dr. B's nodding. You agree with me?
Yeah, I mean, I practice in Southern California, and we have a lot of patients who have naturopath doctors, right? And I mean, I'm kind of low key jealous of naturopaths, to be honest with you. I wish I had like some ND, MD kind of hybrid, because I think it's such a fascinating training and such a compliment really to what we do. Unfortunately, I think that older generation just sees it as competition, and I see it more as collaboration. So I think you're going to get, a lot more kind of open mindedness with a younger doc on this one. I'm not saying that all long in the tooth docs are obstructionist or anything, but I feel like as we get younger, there's more appreciation for these other points of view and the other healing arts as well. Or at least I hope that's what happens.
It's so great. So, all right, let's talk about a lipid panel for a second. A lot of people have heard you got high cholesterol or you have high bad cholesterol or you've got high triglycerides. And so many people come home from the doc hearing that and they do one of two things. They either go, I got to stop eating fat, or I got to stop eating sugar. And I think there's some nuance actually behind that that sometimes patients don't get taught. So, can you tell us if someone came in and they had high cholesterol, high triglycerides, how would you talk with them about what it meant, what caused it, and how to bring those numbers down? And even more importantly, why? Like, why does cholesterol and triglycerides matter for heart health? Why should we care?
Right. So many things. So somebody comes in, and I think it's important here to distinguish two groups of patients, right? So there's what's called primary prevention, and these are people that have never had a cardiovascular event, right? So it's someone like you or me who we have high cholesterol, but we've never had an event, right? Then there's the what's called secondary prevention group. These are people who've already had a heart attack, had heart bypass surgery, had stroke, so that's a separate group of people that we have to be more aggressive with. So, let's put those folks aside, right? And talk about primary prevention. So you're in your 30s or your 40s or early 50s and you say, "You know what? I got to take care of myself. I'm going to go to the doctor on my birthday," and you get a lipid panel done and something is off, right? And so how do we approach that, right? So the conventional medicine approach would be like my doctor said to me, "Here's four medicines, see you in 6 months," right? But that's not the right thing to do. That's not what our guidelines say. It's just as humans, not what we should be doing, right? Because this next phase of my career, these next chapters are really kind of trying to optimize diet and lifestyle. And so that's the conversation I would have with that patient is, all right, tell me about your lifestyle, right? And it's not just exercise, right? It's sleep, right? Are you sleeping enough? What does your sleep look like? Tell me about your stress level, right? All these things as the root cause podcast folks know, that's inflammatory, right? And so inflammation, I think, is really what we need to be aiming for. Looking in the diet, and I think that demonizing one macro versus the other never gets you in a good place, right? Because you can't just eat protein, you can't just eat fat, you can't just eat carbs. You need everything in your diet, right? And so, when people go on these extremes, then first of all, I don't think it's sustainable. But second, long term, you would probably end up seeing some sort of nutritional deficiency that manifests in some other way: anxiety, depression, stress, all of these different things. And if you're looking to learn more about that, there's a wonderful lecture done by our very own Dr. Kate Koreski that was just absolutely fascinating. It was like I was sitting there like eating popcorn, just waiting for the next word out of her mouth. It was absolutely amazing. But, let's focus on diet lifestyle issues first, right? And so, really drilling down into diet. Fast food is a necessary evil sometimes. Look, I've got triplet girls and they're in sports and this, that, and the other. And I get it. Like, it would be lovely if I could just go out to my garden and pick the tomatoes that I grew from a seed with my organic water, sourced from unicorn tears and all this stuff. But we have to get change, right? Like, we have to create change in the framework of reality, right? And so maybe that means, and I tell people, you get, if you're eating, 3 meals a day, right? So that's 21 meals a week. You get two wild cards, I call them, where you can just kind of, you can go out to a restaurant, you can have fast food, whatever. But the rest of the time, I want you to eat compliant, right? So what does that mean? So we really kind of drill down on, what are the proper meats? What are the proper vegetables? Getting ultra processed foods out of the diet. You'll love this. I just heard somebody, like I was reading an article yesterday where they called ultra processed food pre-digested food. Gross, right? Like, oh, that definitely made me never want to eat ultra processed food. That just sounds like some sort of crazy elemental diet. So let's kind of drill down into what your diet looks like and let's triage. What are the main things that we can do, right? Because I don't think a busy mom of 3 kids can go an hour walking on a treadmill for an hour 5 times a week, right? That's not practical, right? So I like to be tactical about how I deploy these kind of wellness initiatives and start with kind of the low hanging fruit. Let's see if maybe we can, sub out French fries and sub in salads, right? Let's see if we can kind of, identify some sort of a very pro-inflammatory food that we can get out of your diet. Let's look at your sleep habits and say, hey, you know what? Maybe you don't need to watch 4 episodes of that Netflix show every night. Like, maybe let's prioritize sleep for 2 weeks and let's see how your brain feels, right? Let's give your brain that time for recovery. Let's do box breathing at every stoplight. Every time you're at a red light, let's do box breathing for 2 minutes or 30 seconds or whatever it takes to kind of tone down that sympathetic tone, get your heart rate variability up. So those are the lifestyle and diet changes that I would start with in clinical practice. And then, of course, giving people a structure and a framework to make that change. Because unless I can tell you, run a marathon, right? 26.2 miles, it can be done. But unless you're training and ramping up correctly, it's really hard to just, slap on a pair of shoes and go run a marathon, right? So doctors need to take the time to give that structure framework. And that is why I honestly think it never gets done, because in a clinical encounter, you're looking at the computer screen for, out of a 15-minute clinical encounter, we have so much documentation that we need to do. It's like 12 minutes of looking at the computer and then maybe 2 minutes at most kind of actually engaging with the person in front of you, right? So sorry, I kind of soapbox a little bit, but I think that really kind of engaging this diet and lifestyle change becomes super important and so beneficial for folks.
So it sounds like your conversation with clients was not sugar is causing your high cholesterol or fat is causing your high cholesterol. It's much more holistic than that.
Yeah, and carbohydrate leads to triglyceride biochemically, right? And if you're looking at, like, in a lipid panel, for instance, what is the main driver of triglycerides? Well, it's carbs, right? And what's the one thing that you can change the quickest? Go on a low carb diet, you'll see those triglycerides fall within a week, right? You were talking about cholesterol. The dietary contribution of cholesterol is actually not that much, right? So when we talk about, eggs are horrible for you and all that stuff, all this language that we are getting, about 10 or 15 years ago, it's actually not that bad. I mean, sure, if you're eating a dozen eggs a day, maybe, but for most people, what my belief is, it's really inflammation that drives that. LDL and the lipids are an acute phase reactant, right? So they react to inflammation. And as I read the literature and we're getting more and more about like oxidized LDL and damaged LDL particles, I wonder if we're kind of right for the wrong reasons when you talk about LDL. I mean, there's definitely association with higher LDL, higher cardiovascular events. But I think that that's probably, if we had the science 20 years ago when a lot of those trials were done, but now we have the science looking at damaged LDL particles, oxidized LDL particles. That's really what's driving atherosclerosis and vascular events. And what drives that oxidation? Well, ultra processed foods, inflammation, leaky gut, leaky vessel, too much sugar in your diet, right? All of that stuff drives that oxidation. And I kind of tell, when I talk to patients, I say it's like you're caramelizing your insides. That's a pretty big visual, right? So when you caramelize these insides, yeah, your body reacts to them. There's an immunogenicity associated, there's an immune response associated with anything that's damaged in your body. And cholesterol particles are no different. The only problem is to sequester those cholesterol particles, they get packed into the blood vessel wall, into that media of the blood vessel, and that leads to vascular events, right? So how do we stop the insanity? We've got medicines and anti-TNF and anti-IL-1 and all that stuff, but hey, let's just start with eating the right things and getting the garbage out of our diet and really moving and doing simple things that we're supposed to do, that we're designed to do.
Beautiful. So, are there any natural interventions that you would recommend that people consider for lowering cholesterol? And let me give you an example of what I'm thinking. Fiber is so overlooked. I feel like in a lot of these conversations, if someone says, like, okay, yeah, Dr. B, I'll eat more plants and I'll look at your list of foods I'm supposed to eat and I'll try to only eat fast food like 2 times a week. But aren't there any supplements? Aren't there any things I can add to my water? Like, how do you talk to them about that?
Yeah, so I think fiber has a role. And the reason fiber has a role is that so much cholesterol is actually circulated in your gut through bile. So bile salts are made out of cholesterol. And so there's this what's called enterohepatic circulation. So from the liver to the gut, the circulation of cholesterol that gets reabsorbed. So when you talk about fiber, something like cholestyramine, which is a bile acid sequestrant, essentially what you're doing is just you're binding up that bile salt so it can't get reabsorbed, and then you're shifting the cholesterol back to bile production as opposed to floating around in your bloodstream, and it does great. So, it's just that I think that the clinical benefit is underwhelming, like in comparison to some of the other cholesterol medications. And so when all you're doing is treating a number, as most doctors do, and somebody goes on fiber, all right, it might move like, 5 or 6 points, which is underwhelming. But we know that fiber has so many other benefits for you, right? The prebiotics and feeding the beneficial bacteria and all those other great, regulating bowel movements and all these great other things. But I think in the cardiovascular circles, because it's seen as an inefficient therapy for cholesterol, it's just not used very much. But, unless you're eating rope all the time, I don't think anyone has enough fiber in their diet, right? Another one that I'm a big fan of is berberine. I've had some hyper responders to berberine. I think of it as kind of this just metabolically gifted supplement that helps balance lipids, helps balance blood sugar. It has an AMPK mechanism similar to metformin. So you see some blood sugar regulation out of it, rebalancing the microbiome. I don't think you can go wrong with berberine. Bergamot is another one that I used a lot in clinical practice. So I always started with berberine. But if I couldn't get them there, I would add a bergamot supplement in there as well. There's always something new coming up. There's now these probiotics that people are touting. And truth be told, I just am kind of learning about these. But, it's like a designer probiotic to help with vascular health. And I say, why not? Right? Because, at some point when you think of the microbiome, are we running it or is it running us when you think of the dopamine and the serotonin and all the things that secretes and creates, right? And in the traditional cardiovascular literature, there is actually this, in our Journal of American College of Cardiology, I remember probably about 2 or 3 years ago, there's an article discussing the microbiome in heart failure. And I was very proud of the American College of Cardiology for publishing that. I think we'll see more of these therapeutic kind of designer prebiotics for all sorts of different cardiovascular conditions because, again, I think it's driven a lot by inflammation, right? So balance the gut, balance the inflammation, save the body, right?
What do you think about red yeast rice? So, I will say I had one client come in who did not wanna go on statins, really didn't, but had a total cholesterol of almost 300, and which is pretty high. And so we put her on high dose red yeast rice, CoQ10, tons of fiber, tons of antioxidants, lots of movement because we know that exercise can help shift some of your more oxidated or LDL cholesterol over to HDL, which is, we think, a little healthier for your heart. And her cholesterol dropped 90 points in a couple weeks.
Yeah. So, I mean, sounds like that was like a, nuclear bomb that we put on her. I mean, red yeast rice, I tell people, it's a statin, right? It's a natural occurring statin, right? And so that's like someone saying, well, I'm alcoholic, I don't drink, but I'll have a whiskey, right? Like it just, if you're really truly worried about statins, and not to say that there's not concerns for statin drugs, because certainly there are, but I had people all the time that said, I don't want to be on a statin, but I take 10 pills of red yeast rice. And when I told them, well, if you look at the active compound, that's where statins were derived from, right? Lovastatin, was like the original statin and it was derived from red yeast rice. they look at me like I'm from Mars, like they just don't believe it. And I think so many of our medicines are plant-based, right? So that's great, right? But at the same time, sometimes you have to treat the mentality as opposed to treating the medical condition, you know what I mean? As a provider. And if somebody says, when I look at the bottle of statin and my muscle aches, but I can take 1,000 milligrams of red yeast rice and I do just fine. Look, if it's working, right? And the only thing I caution is that we just don't have the literature. So I can't tell you if you're on, red yeast rice, that's going to lead to a 2.6% risk of cardiovascular events or whatever that number is, right? I just pulled that number out of the air. But look, if it works for people. And you have to meet people where they're at, right? So I've had so many patients over the years that they didn't want to be on a medication. And I said, okay, we'll try it your way for a while. And we worked with the natural medicines and the statins and things. And then eventually, if they were where they needed to be, great. But at the same time, as a practitioner, and I kind of toe that line of functional and conventional, it's like a ping pong ball sometimes bouncing back and forth, particularly in that secondary prevention population that I mentioned, those people who have had cardiovascular events. You got to do what you got to do, right? And so if they're not going to take a statin, but they take red yeast rice, you just give them the risks and the benefits. And, these are big boys and big girls, right? They can make that decision on their own. But I think the wrong thing to do is just force feed somebody meds, right? That's just never right.
When you would prescribe statins, would you also prescribe a CoQ10 supplement? And can you tell our listeners why if you did?
Yeah, so statins naturally deplete coenzyme Q10. So statins work on this enzyme HMG-CoA reductase, which is in the cholesterol synthesis pathway. And I'd have PTSD and I might go into seizure if I talk about biochemistry or anything more than that. But it depletes CoQ10. CoQ10 also cofactor. It's in like everything. It's ubiquinone, right? It's literally like named. It's everywhere, right? So you definitely need it. So some people will feel muscle aches and pains, or they just feel off with CoQ10. There was a time in, I want to say, like the late 90s, early 2000s, where it was standard of care to give a CoQ10 supplement with a statin anytime, and people seemed to do okay. And for whatever reason, that kind of trailed off, partly because there were some studies that showed that the actual CoQ10 content of supplements was so variable that we weren't sure what they were getting. So the actual content of the CoQ10 supplementation was variable, and so you weren't really sure what you were giving patients. Now, rather than kind of giving it to everybody, I give it more purposefully. So when I see people who I think maybe CoQ10 depleted, or if they get symptoms, like I always have a phone call or email or something within the first week of starting a new med and say, hey, if you're feeling a little bit off, try the CoQ10 supplement.
Yeah, I hear you. It was really cool. I was like looking through the literature the other day, and there was a meta analysis of studies on CoQ10 and fatigue. And they found that there was a statistically significant increase in energy when people would take CoQ10 if they were fatigued. And I thought that was really neat because it's just a nutrient. And it totally makes sense based on the biochemistry. You're like, you literally need it to create ATP in your body. Like, why don't we think about it more in medicine? Like, we think about it with statins.
Well, I'll tell you why, because, that's buried away in biochemistry in first year of medical school, and you just see it as something that's not relevant to clinical practice, when in fact it's the most relevant thing in clinical practice. Let me interview you for a second here and talk to you about micronutrients and health. And like I said, for those of you who haven't seen it, an absolutely fascinating, eye-opening lecture. But what are some of the micronutrients and the vitamins that you think are most absent in our diets that we really need to either get through fortification or supplementation? Because I was surprised by those numbers that you spit out there.
Yeah, it's interesting. What I always quote in my presentations is actually NHANES data, which all of our tax dollars paid for. And so according to NHANES, the top nutrient deficiencies are B6, iron, vitamin D, B12, folate at a minimum. And so I think anything with a B, you can just assume is related to energy in the body in some way. B6 in particular is needed to make dopamine and adrenaline. And so I always bring that up when I'm talking about depression or ADHD or PMS, even. So I think those are critically important. What I think we probably aren't measuring correctly, and I we're just postulating, guys, if you're listening to this, like I always survey the docs that I'm teaching about this and I go, what do you guys think are the top nutrient deficiencies? And when I'm talking to functional medicine docs, they always say CoQ10, magnesium, right? Like they bring up some of the micronutrients that we tend to see people benefit from in clinical practice. And it makes me think that at a national level, when we're doing these surveys, we're probably not catching these deficiencies because we just may not be measuring them correctly. I have a feeling if we actually screened for like CoQ10 inadequacy, we'd probably find a lot of it, but we just don't have the data right now. So what we have the data on is the Bs and some of the minerals and definitely vitamin D. And a lot of the foods that are high in these nutrients are plant foods or organ meats, which generally are high in many nutrients at once. So this is where, like, again, if you're part of those presentations, like, you'll just be like, "This lady is pushing liver and oysters so hard." Like, what? She's a naturopathic doctor. She's supposed to be talking about plants. But, like, you look at when you look at the top source of these nutrients, which comes from the NIH, again, tax dollars are paying for this. These tables of nutrients are like, if you wanna get the top food source of, these vitamins, eat beef liver. If you want the top food source of zinc and copper, eat oysters. And it's because other mammals tend to store these nutrients in their organs. And so when we eat their organs, we get these nutrients. So it all kind of comes together when you study nutrients and what they do in the body and then the top food sources of those nutrients, you end up with a very short list of foods that if you just consume them regularly, you're likely to be replete. And it's the same list of foods that you talk about in Well 12.
Yeah, and how many of those foods come in a foil bag or a box?
Well, none of them, right? Because we've evolved up until this point, and we've really only had processed foods for the last 50 years. And so before that, we had to get them somehow. Like, again, when you start to read these lists of nutrients and you go, huh, like fully 8% of Americans are deficient in vitamin D. And that's really interesting. You need like a certain amount per day, and only cod liver oil, two tablespoons a day would give you enough. You logically start to think, how did people survive before supplements and fortified foods? Right? And then you realize, oh, because they were eating these traditional foods, they were eating beef liver, they were eating cod liver oil.
This is where I feel like there must have been like aliens that came down to instruct the first humans how to eat or something. Like for the South Asian, like I'm Indian, so the Indian diet, turmeric, garam masala, like one of the first IFM lectures I went to was like, oh my God, like I eat Indian food, I should be invincible, right? It's got all these curcumins and all these things, right? It's amazing. Like for a population of people that is so at risk for vascular health, it is amazing to me that the foods that we naturally eat, right, are so high in like the antioxidants, these anti-inflammatory compounds, and even more so, the combinations, right? So rice is an imperfect protein, beans rice has incomplete protein, beans incomplete. You put them together, rice and beans, it's a complete source of your like this can't just happen by accident.
I love it. Hey, I want to ask you this. Actually, I've been meaning to ask you this. We get a lot of questions about LPA, and I think LPA is kind of like this emerging aspect of the science where, like, we've got the biomarker, but we don't know what to do with it. Tell people at home, what's LPA? Why might they have heard of it? What do you do if it's high?
Yeah. So let's maybe back up because I think you had mentioned ApoB as well, and I just let's talk about lipoproteins for a little bit here, right? So when you look under a microscope, right, at these particles, it's not written LDL or HDL on there, right? So what we look for are like cell surface proteins, right? So you've got the little cellular structure, and you look for things on the cells to say, oh, that has this thing, therefore that is, that has apolipoprotein B. Therefore, that is an LDL particle. That has apolipoprotein A. Therefore, that's an HDL particle, right? So there's tons of these things. And even subspecies, there's ApoB48, ApoB100, there's apolipoprotein A, A3, A1, all of these different things. And so one of these that's come up more recently is LP little a, lipoprotein little a, which is different than LPPLA1, right? Which is a marker of vascular inflammation, right? And you can get lost in the alphabet soup of these names. But LP little a is a cell surface protein on LDL particles, which are the atherogenic particles, which makes it super atherogenic. So I think in one of my IFM lectures, I said, if you see like somebody with a teardrop tattoo, like, that's a bad player. Shout out to all my teardrop tattoo folks on there. But, I grew up with a very conservative Indian mom. And she said, anyone with a tattoo is bad, right? Now it's a little bit different. But so if you've got this LP little a marker, it suggests that your LDL particles have a much more atherogenic potential. They are much more likely to cause plaque. And the problem is that we know about the existence before we have a therapeutic. So as you very correctly asserted, is this is now an emerging risk factor, right? It's an emerging particle that if you're seeing someone who is watching the Root Medicine Cause podcast or is ahead of the game here, they're going to be able to check that LP little a. Problem is right now is that we don't have a direct therapeutic for it, right? So there's not like a medicine that you can take. Or for that matter, we're not even sure yet with 100% certainty what the outcome of bringing LP down will be, right? And so whenever we see a medicine like this come into clinical use, right, there's two things you want to do. Number one, does it change the biomarker of interest, right? And often that's the first study, that's a phase 3 study or something that's done. But then we want to look then kind of beyond that is when you do then change that biomarker of interest, are you seeing a difference in mortality, right? Or heart events, heart attack, stroke, fatal MI, non-fatal MI, whatever, we call that major adverse cardiac events, coronary events in the cardiology literature. So right now, there I think are 3 medications in clinical trial. One was reported, I think, a few months ago at American Heart Association, showing that you can change Lp(a). We just don't know what that means, right? And so I'll go back because these are silver hairs of wisdom here, right? So going back a few years, that they found, I think, in a village outside of Milan, Italy, that it was one of these blue zone places that people lived forever, and they realized that they had a different type of HDL, an ApoA. I think it was ApoA Milano is what they called it. And so humans being what they are and scientists being as smart as they are, they said, all right, well, if these guys have and they live forever, let's just make a ton of this and inject it into people, and these people will live forever, right? Problem is that's not what happened. So people who had the ApoA, like Milano protein injected, actually died faster than, so they had to stop the clinical trial. And so that's where I'm always cautious with these lipoprotein, the next great thing, because there's always a next great thing, right? And there's an LPX, by the way, which just sounds awesome. Like I want that hat and that t-shirt. But there's always these lipoproteins. So we just need to see, number one, we recognize that it exists. So that's great, right? But now that we change it, is that leading to an improvement in outcomes? And so those studies are being done. They're not all reported yet, but the lipid community is watching with bated breath as to what's going to happen. So, if you do check it and it's elevated, right, then let's talk about what to do there, right? Because if you check it and it's elevated and you're like, oh my God, I'm going to die. I have to get my will in order and I'm just going to get a bunch of credit cards, max them out and go live on an island somewhere. No, you can. Best you can do is actually to optimize your traditional risk factors. So let's, talk about exercise. Let's talk about eating. Let's talk about getting your cholesterol under control, whether that's through diet and exercise, supplementation, or at that point, if you have a really high LDL, this is where I have to put my conventional, functional hat off, conventional hat on. If you have a really high cardiovascular risk, then maybe you need an advanced lipid medication like either a statin or some of these other injectables that are available to really drive down that cardiovascular risk.
I love that explanation. It's interesting. So my dad won't mind me talking about him. So my dad's an engineer. Brilliant. Call him Dr. Dad. Because since retiring, he has become obsessed with functional medicine, right? So he's like checking all his biomarkers and he's like, Kate, LPA, it's elevated.
Is he a mechanical engineer by any chance or electrical?
Electromechanical.
You know, I always knew the electrical and mechanical engineers in my clinical practice because they would just come with like reams and reams of data, very data driven. So boom.
So data driven. He's like, LPA is high. What should I do? And I'm like, every other one of your biomarkers is normal. But when they are not, you need to take it more seriously. Like, that's kinda the way the analogy we used was, like, having really high LPA is gonna make a 2-alarm fire a 4-alarm fire for you. So, when your doctor does tell you, "Hey, your cholesterol's elevated, your blood pressure's elevated, you're not exercising enough, you're not sleeping well," you need to treat that as kinda, like, double the level of concern you might normally have, and that is not a clinically proven analogy, folks at home, but just, like, if everything else is normal and fine and optimal and healthy, don't waste your time, like, feeling stressed about the LPA. Stay on top of your biomarkers, stay on top of your risk, stay in conversation with your doctor, but, like, don't walk around feeling afraid. You also are gonna need to take everything else seriously.
Yeah, well, optimize, so it's like the serenity prayer, right? Like control the things that you can control and get peace with what you can't control. And that really goes for a lot of these screening tests. So carotid intimal medial thickness, coronary calcium scores, is that when it's there, it's there. So look, optimize what you can, right? Like it's amazing. Again, getting back to diet and lifestyle, it's amazing what diet and lifestyle alone can change. There was this great study done by this Dr. Amit Khera, Khera, from New England Journal of Medicine in 2016. That was really one of the eye-opening studies for me when I really kind of was going through this crisis of conscience as to, what can I do from diet and lifestyle. So this guy, he's a cardiac geneticist and did what's called a genome-wide association study. And so he looked at 38 markers of cardiovascular risk. So 38 genes, if you have them, they put your risk, and put these people in buckets of low, intermediate, and high risk, right? Easy, right? You have like 34 of the 38 genes or whatever the numbers were. You're in the high risk, you have 0, whatever your low risk, right? But then he kind of further stratified them by lifestyle, right? So did they exercise on a regular basis? Were they sleeping appropriately? Were they smoking? Were they eating, 50% of the meals of plants? Just very simple stuff, and further substratified them and got some pretty cool results. Unsurprisingly, the people who had the blessed genetics and the most favorable lifestyle did great. I think it was something like a 2 or 3% risk over 10 years. The people who had the worst genetics and the worst lifestyle, right, unsurprising, did the worst. I think there was a 10.7% risk. But the magic was in that group of folks who had the high genetic risk, but the favorable lifestyle. So like you were talking about with your dad, controlling the things that you can control. And what happened with those guys? Well, bad genes, but good lifestyle, you actually take that risk from, I think it was 10.7 to 5.1. So you're decreasing that risk by 50%. But the way the stats worked out is that now with the standard error bars, you're indistinguishable from that blessed genetic, great lifestyle folks. So I had that graph on my desktop in my clinic all the time, and I would show it to patients, and I call it the weirdest pep talk you've ever had, because the intent of that is, look, I mean, you have the heart disease in your family, you have all this stuff. Yeah, you know what? You can't go back and choose different parents, but what you can do is choose how you live tomorrow, right? And how you live today, and make those lifestyle changes and marginalize whatever risk you can and optimize whatever you can with what you got. And don't stress out about, if you know that you're doing everything that you can do. Nobody in the history of humanity has been immortal, to my knowledge, right? So we all kind of eventually pass away from something, but don't obsess about it. Don't let your obsession with living forever affect your life today. Right? Because people get so obsessed about this. And we want to bring joy and happiness and, and conversations about things going on in your life other than his LP little a, and that his blood pressure was 121 in the morning, 122 in the afternoon, and 120 in the evening. These are the sorts of discussions I had with my mechanical engineer client or patients, was that, look, there's a little bit of variance. You're an engineer. There's change here, standard error, but do what you can, right? But that means don't do nothing. Yeah, do something. And if you can, do everything. But start by starting, right? And don't get so kind of in this analysis paralysis mode that 10 years go by before you go out for a walk, right?
I love that. It's brilliant. You mentioned actually calcium score, the looking at your carotid artery. So, I mean, people are doing these now without their doctors. Like, you can kind of go get these.
You can get them on Groupon here in Orange County.
No way.
Somebody came with me and they said, "Oh, I got a Groupon." And I was like, number one, that's still a website. And then number two, like, really? Like, that's, like, I think of that like I'm going to go, skydiving or something. And, there's certain things you want to pay full price for. And I think skydiving would be one of those. But actually, a Groupon for a calcium score is probably not that bad of a deal. But you want to talk about calcium scores for a little bit here?
I would love to do that because I think people hear about it. They're fascinated, but they're kind of scared and they don't know if they need it or not. Like, so yeah, tell us, what is it?
So, a coronary calcium score is a low dose CT scan that's done of the chest, of the actual arteries of the heart. And why I like it as opposed to like a risk calculator, so there's something called the ASCVD risk score, is that it gives you an idea of what's going on inside you as an individual, right? So I can see when I had my calcium score done what my heart looked like, right? And if you want to talk about something that lights a fire under your butt, like that will do it, right? So where does this calcium come from, right? So getting back to the top of the conversation about the adventitia, media, and intima, right? When you talk about plaque, what happens is you get the leaky vessel, as we talked about, through the endothelium, and these damaged LDL particles, these cholesterol particles that sequester inside the blood vessel wall in that kind of space between the intima and the media. And when you get all those bad players together, what they do then is try to secrete enzymes, right? Or inflammatory markers that lead to disruption of the blood vessel architecture. And actually, for lack of a better word, try to digest it. So, all these interleukins and matrix metalloproteinases and all of these different things are trying to eat at your blood vessel wall. which is an incredibly bad idea, right? You don't want a hole in your artery. So, what the body then does is it creates a moat around it or builds a wall around the prisoners, if you will, with calcium. So, that's this coronary calcium score, then kind of tries to quantify how much calcium you've got. So when we do the CT scan, calcium shows up white. And so we can take measurements, and then you get compared to an age matched cohort of individuals. And we see, based on your age and gender, you fall in the 50%, meaning you're average. You've got about as much calcium as we'd expect, or you're amazing. You've got 0% calcium. You're in the 0 percentile, or you're in the 99th percentile, meaning that you've got a heart age, if you will, of like a 90-year-old person, even though you're 47 years old. So that kind of acts as some motivation. But again, I think it's good because it gives you an idea of actually what's happening. Similarly, with intimal thickness, you're looking at that media, that middle layer of the artery, to kind of see the thickness as a marker of how much stuff is in there, right? What the atherosclerotic burden might be. So they're important tests to have, but just for the listeners of this podcast, I'm going to clue you into the dirty secret of cardiology. All right, don't tell anybody, right? But, right, the calcified plaques are not the ones that rupture and cause heart attack, right? And this is why I think when people have a 0 calcium score, I'm still afraid, because non-calcified plaque, or what we call soft plaque, that you have not yet built those walls around the prisoner, so to speak. So you have all those enzymes that are trying to digest the walls. Those are the 20, 30, 40, 50% lesions that don't cause symptoms, right? That don't cause chest pain or shortness of breath or toothache or whatever symptom might be. Those are the ones that rupture, right? So that's where a calcium score alone, I mean, don't get me wrong, a 0 calcium score is great, but you need to always do that in concert with, or at least in my clinical practice, what I did was always check it with markers of vascular inflammation, because it's a very different thing to have a 0 calcium score with normal markers of vascular inflammation than to have a 0 calcium score with sky high markers of vascular inflammation, right? Because if you have those sky high markers, we've got some work to do still, right? So it's an important test. It's a readily available, easy test to get, probably coming to your, drugstore near you or whatever it might be. But as with anything, right, you need to know how to interpret it correctly, right? And I think that's where sometimes people get that false sense of security if they have a 0 score, because you can still have non-calcified plaque, and that's the stuff that you really need to watch out for. But on the flip side, that's also the plaque that is really responsive to dietary and lifestyle changes, right? So eat better, exercise more, and reduce your inflammatory burden. And you see those vascular inflammation markers go down, and people do great. So that's my little 2 cents on calcium scores.
I love that. So even if you have an elevated calcium score, it will respond to diet and lifestyle. So then you could do it again in a few years and you might see a change.
Yeah, so calcium score, once it's there, right? So what you're aiming for with that, you rarely, I don't think I can tell you in my clinical practice, unless there is some sort of an error of calculation, I've never seen it go backwards. But what you do is you kind of modify the slope, right? If it's getting worse like this or worse like this, those are two very different clinical situations, right? So what you want to do is kind of level off that progression, and that's really where the win is with calcium scores. Just by the by, because there is radiation exposure and X-ray, and we don't want to irradiate people's chests too much and stuff. Generally, when I had patients, I would recommend it no sooner than every 5 years. You're going to see the progression, but you're not going to get all that X-ray. There's a lot of important structures in the chest you don't want to deliver X-ray to if you don't need to.
Okay, I like that. Brilliant. And then you mentioned so you want to do it in concert with the vascular inflammation markers, but let's make sure people know which ones those are because they wrote down your list you said earlier. Which one of those do you consider to be vascular inflammation markers?
So I think the easiest one to get is CRP. So it has to be high sensitivity CRP or HSCRP. I like myeloperoxidase, MPO, and going back to our other conversation, LPPLA2. So those three I kind of consider, and it kind of runs with the neighbors a little bit. So if you have an elevation of one, but the other two are normal, I tend to look for other kind of, joint issues or dental issues. Dental inflammation is in a cardiology population a very common thing. So if I didn't see kind of all of them elevated, but just like let's say a myeloperoxidase was elevated, I'd look at the teeth and suggest maybe some periodontal work or something like that, because there is a mouth heart vascular connection as well. But specifically, yeah, for vascular, high sensitivity CRP, MPO, LPPLA2, that was like a blue plate special in my practice. I would just check all those together.
Brilliant. Okay, cool. So someone just heard you and thought, hang on a second. He's a cardiologist, not a dentist. Why is he talking about my teeth? Why would you automatically go to the mouth if someone had elevated MPO or CRP?
Well, so periodontal disease, right? Inflammation in the mouth leads to inflammation everywhere, right? In the most extreme circumstances in cardiology, you can actually get infections of the heart called endocarditis from aggressive dental manipulation. I've seen probably 2 or 3 cases a year from that. And so inflammation starts in the mouth, right? So, if we can take care of that inflammation in the mouth, you've got leaky mouth, you translocate bacteria into the bloodstream. There's a thought that there are microbes that are associated with atherosclerotic disease. Chlamydia pneumonia, for instance, C. pneumoniae, was implicated in atherosclerotic plaque as well. So you just, you want to give your body the best shot it has at being healthy, right? So take care of your teeth, see a dentist on a regular basis, get your gums checked out because that's oftentimes a conduit. And that was something actually that I learned really in the functional medicine training through IFM that we referenced them before, is that I was like, what, your teeth? Like, I was that guy. I was that cardiologist. What is this cardiologist talking about teeth? And I remember the first time I started checking people's teeth in the cardiology clinic, I had one woman asked if I was going to do a pelvic exam. I'm like, no, we're not going to do that. Right. Like, but she was one of my fun patients. But, I think that it is an important thing, right? Because we have these windows into the soul, and the mouth is something so easy to see. So yeah, I might have been one of the few cardiologists that would take a tongue depressor and look at the teeth and be like, hey, there's a hot mess going on in here, you need to get this checked out, because there's now clear literature that shows that that oral health and that inflammation leads to cardiovascular symptoms as well. And it's such an easy thing to do, open up and say, right, like, it's easy.
I love that you checked for that because it's so interesting. I think we know that the research is there, and I'm sure the average cardiologist would nod and go like, "Yeah, yeah, I have heard that." But translating it into the clinic so that it really starts to help your patients, I think is the key. So I love that you would actually do an oral exam.
Well, and one of the things I think that I enjoyed most from this functional medicine journey that I've been on is seeing the amazing interconnectedness of everything, right? Like, it's amazing when you think about the nodes and transport and all the different things, how they're really connected. And of course, I'm a cardiologist, so to a hammer all the world looks like nails, right? So for me, I see everything relating to the heart, right? Assimilation and transport and all these different things and optimizing this, right? But I think that that's the cool part of functional medicine, is really like seeing how everything just kind of comes together. It's like that scene in the movies where all of a sudden you've got that aha moment and everything makes sense, right? Oh, he's the killer because he was behind this and he has the same trench coat, and I can see that fiber that they got off the car seat is from his pants, or right, like, oh my god, everything makes sense. And it was the first time in my career I was like, wow, like, I feel like I'm really seeing through the matrix here, and like everything is just connected. And how are hormones connected to cardiovascular health? If you asked me about testosterone and estrogen 5 years ago, I would have been like, I have no idea. But now, there's, you can see how they're so interconnected. Thyroid hormone, right? Every cell in the body has thyroid hormone receptors, other than red blood cells probably. But I mean, you have to be able to put these things together. And I think that conventional training, we're so used to siloing everything that we're really doing patients a disservice, right? Because unless you fit neatly into one of those silos, you're labeled as kind of a weirdo, right? Like, and that's like the worst. It's the most horrible thing that we can do as a healthcare system, is alienate someone who's asking us for help, right? So we talked about building the team and building the village, and that's why I just love having this approach where you've got DOs and NDs and MDs and the whole world coming together, and really just focusing on individuals. I feel like you should have like a council of health for every individual, right? Like, and like, just put them all in the same room and let's just all hang out and fix people. Like, right? Maybe that's the clinic I open up now. Who knows?
Do it. I'll come. I'll come. I'll bring my family. They can all be your patients. I want you to talk about testosterone for a second, and if you and maybe estrogen, because those are biomarkers that people can add to their list as well for their doctor to check along with thyroid. But there's a thought out there that, okay, I know doing steroids and too much testosterone is bad for my heart, but I don't think we talk about testosterone deficiency or estrogen fluctuations and how they affect the heart. Do you have a spiel that you would use to explain to clients why those hormones matter for their heart?
Well, I mean, I think that, getting back to that longevity hat, right? I mean, part of the reason that we feel so horrible as we age is that those hormones that we've become accustomed to just kind of go away, right? So it's kind of natural. And certainly as humans, we're outliving our design, right? Like, we're probably supposed to die when we're 40. I mean, hopefully that doesn't happen to me, but like in caveman times or whatever, you get eaten by a pterodactyl or whatever, and so you don't live. But now that we're older, I think we're seeing a lot of these things. And honestly, when I look back at the conventional literature, I feel that a lot of it was done with agendas, right? There was an agenda to show that there was more horrible outcomes, and there was an agenda to show that women, but when you then kind of look back and kind of rehash the data, we see that, what, it's actually helpful for people, right? Like, I'm not saying get on super therapeutic doses and have to shave your eyeballs every day, doses of testosterone, right? But just getting people back in a normal range. Understanding the difference between free sex hormone and bound sex hormone, right? So sex hormone binding globulin, I think, is if we're getting like to the expanded Dr. B panel, right? Like, I think sex hormone binding globulin is an important thing because as we get that visceral fat, right, as your musculature kind of wanes off, as we lower our activity, sex hormone binding globulin goes up. So your total hormone level might be normal, but the free active form is just all gummed up, right? So, I think that there's a lot that I've learned on the functional journey and I've become much more tolerant of it. Now, I definitely have that conversation with clients or patients, I should say, and say, you know what? The literature suggests this. I think newer literature forthcoming is probably much more reliable. But if you feel better, right, then that's great. And now, when you're looking at some of the newer literature about normalizing testosterone and cardiovascular outcomes, it's actually pretty impressive, right? Because people are holding on to muscle mass, they're able to burn fat a little bit, eat more easily, but actual vascular health improves significant, endothelial function improves significantly. So that's one where I think that as we look at the next 5 to 10 years in cardiology, I think that's an area that we can really improve on is getting more reliable, modern information that doesn't have an agenda about hormone replacement. And, I'm not saying that you will feel like you're 17 again, but at the same time, you don't have to feel like you're 117 either, right? There's some happy medium in between and getting it within like a normal functional range. Because as we know, the functional medicine ranges really have to do with symptoms, not numbers, right? So where you're functioning correctly, right? As opposed to your number is therapeutic, but you're functioning correctly, that's great. And I think part of the reason why that doesn't happen is because it's so individual dependent, right? And it's like artisanal work that most people don't want to do. We want to have this kind of one size fits all approach to medicine. But that's really where I think our community of functional practitioners is exceptional, right? I mean, I think we actually listen to patients. What? Like, really? And when we ask, how are you feeling? We take a moment to actually listen to that response, right? And I think that's really what's going to drive a lot of that, making people feel better. And I think it's particularly important with hormones because they can go all sorts. I know I've seen clinics where it's like a chop shop and people go in and they just get a bunch of pellets. And I had one woman that just got loaded up with pellets and just couldn't sleep for like weeks at a time. And I had to refer her to a surgeon to try and see if we could extract them because this place just pumped a bunch of pellets in her and it was just too much for her, right? So you have to do that follow through and see how people are doing. I'd always say, maybe it might be my own bias, but start low and go high. It's always easier to add than it is to subtract when it comes to those sorts of therapeutics. Be cautious and just listen to your patient.
Yeah, that makes total sense. I think the message I think the average person probably needs to hear is like worth checking. And if it's frankly abnormal, then normalizing it will likely improve your overall health, whether it's thyroid, whether it's testosterone, like, work with your doctor, but probably worth screening if you're going to do an advanced look at your overall health because profoundly low testosterone or profoundly low thyroid is definitely going to affect your cardiovascular health.
Yeah. I mean, look, I had low T and I think it was when I was kind of not so healthy and I actually did compound lifts, right? So I started powerlifting and something as simple as deadlifts and squats and then burning that visceral fat, changing my body comp, I normalized it. So, as we talk about these hormone issues, there's natural things that you can do. I even read something about perineal sunning, which I think you have to have a very specific location for that. Like you don't want to just like drop trout in the middle of the beach, but as something that can boost net. I mean, there are things that can be done, right? So again, don't just go and try to get medicines all the time. Like let's get back to humaning and do things that humans do and see if that normalizes things.
It's so crazy. My husband and I did a podcast years ago where he talked about the compound lifts and how they raise your growth hormone and help with testosterone, and, like, I actually didn't know that at the time. That kind of blew my mind that weightlifting could increase your hormones like that.
It actually works, right? But I mean, think about it. Humans were designed to like lift and move and do things. And if you're not lifting and moving and doing things, the human body is 1,000 times smarter than the smartest doctor, right? And so if you're not engaging in movement in resistance training, the body's like, well, why bother making this stuff? I'm going to shift this energy to something else, right? I'm going to shift these synthetic pathways towards making XYZ. Like, don't waste time on that. But when you engage those systems and you're using them correctly, I mean, it's amazing how the body just wants to work. It's crazy.
That is so cool. I want you to talk to us about exercise because, like, you're a dad of triplets. You were interventional cardiologist, so, like, a lot of time in the hospital, you're busy, and yet you were a power lifter. I happen to know you, like, kinda, were up on the stage powerlifting at one point. Like, what are some of your favorite exercise tips? Like, for somebody who is in the, like, couch stage of couch to 5K, like, how can they get started, and what should they think?
So, number one, start slow, right? So don't go out and run a marathon because your body just isn't ready for it. So you need to ramp up. And I feel like a lot of the January firsters, like people that, oh, I'm going to get in the gym and all that stuff. And they go super hard the first week of January. And then they're so sore and locked in that they can't get back. Like I just started weightlifting again. I had some health issues. And so I got back in the gym, and it is humbling. There's a fine line between humbling and humiliating when you start out again, right? But I'm approaching 50 here, and I'm like, I am not going to overlift and tweak an elbow and then I'll be out for 6 weeks or something stupid. So have the discipline to be disciplined about your exercise. Number two, if you're not used to lifting or exercise, get a trainer, get an expert, right? Like I think that's so important because particularly as we talk about compound lifts, which are deadlifts and squats and overhead press, bench press, these sorts of lifts. The simple difference of having your hands here on the bar versus here on the bar versus here on the bar engages a different musculature, puts different strains and stresses on your shoulders, for instance, in a bench press, or if you're in a high bar squat or low bar squat, and kind of how you engage your core and where you're hinging, that affects your glutes and all sorts of different things. And these are very subtle things, like even putting your feet here versus here and having them wider out. I mean, there's a lot of nuance to these things. So, I definitely think getting an expert in. And then number three is just do something fun. Like my wife and I could not be more different when we go to the gym, right? Like for me, I just put my headphones on. For me, lifting is a meditation because it's me, my breath, and the bar. Those are the only, gravity, I guess. Those are the only things that I have to worry about. I don't like talking to people. Like my kids, when they see me at the gym, they're like, "Dad, why do you look so angry at the gym?" I just like that's my me time, right? That's what I enjoy doing. My wife, you put her in a squat rack, and that's just not fun for her, right? So she likes being on the treadmill or doing other kind of lifts or machines and things like that. So I think the important thing is find what's fun for you. Maybe like I had a couple that they were in their 90s and they did Lindy Hop. So swing dancing still. That was their fun. And they're so cute. They did it together and they showed me their videos and stuff. It was lovely. But that was their fun, right? So I think one of the things when it comes to exercise is don't divorce movement and joy, right? They should come together, right? So if for you that's walking outside with your dog, if that's swimming in the ocean, if that's walking the aisles of a store, whatever it might be, do something fun, right? And then you're more likely to do it again, right? Because if you're forced to do some mind-numbingly boring workout, you're not going to engage. You're not going to do it again, right?
Yeah. I think that's great advice, and I love the joy part. And I think for the people at home who just like you're not self-motivated to exercise, like you weren't an athlete, you'd never like to go to the gym by yourself. But if you are others motivated, I think one way to sort of trick yourself into working out is to do it with someone or to do it for someone. So I feel like a lot of my moms that I would talk to in practice, they just like the gym wasn't their thing. They'd never been. But they would think about their kids, and they'd be like, "Okay, well, I can bring my kid to the gym and learn how to lift with them because they're interested in it, or it'll be good bonding for us, or I can go play basketball with my kids for 30 minutes." Or maybe I'll take my mom, like the grandmom of the family, like maybe we'll go over, we'll take her dog for a walk to get the dog exercise. So for them, it was like if it was about others, they would do it. when they couldn't do it for themselves. And then I think a lot of times when we start an exercise routine, we're like, "What can I do every day?" And it's like, "Don't do that." Like, if you're moving 0 days a week, pick one thing to do the first week, like, just one.
Start slow and then and amp up, pyramid from there. Don't do everything or don't obsess about doing everything because you end up doing nothing, right? So I like what you said. Start with something. I get nervous about mom guilt here, so I'm going to put a big hashtag mom guilt thing on here. But there was actually a study that showed that one of the best predictors of children's health is the degree of maternal exercise that they watch, right? So I think that there's this generational modeling that happens when you see your parents exercise. Like, and for me, it's important, my dad, it's funny. I came the other day from the gym in shorts, gym shorts or whatever. And I was just having dinner with the kiddos. And then I realized that I think in my life, I've seen my dad in shorts like maybe twice, like ever. Like, and working out was like never a thing, right, for him. But because I'm kind of motivated, we've got a garage gym and all that stuff. The girls are like, "Oh, dad, can we work out with you?" And I think it's awesome, right, to be able to give that gift of motivation kind of generationally is a hard thing to break sometimes. So yeah, absolutely, parents, model after your kids, do stuff at home. Calisthenics, you don't have to have, thousands of dollars worth of equipment to do an air squat. There's so much that you can do that's so beneficial without having to invest millions of dollars in equipment and things. Just move, do something, and now there's so many videos online about, how to do this and do this yoga and that body weight exercises and all that stuff. Like, there's really kind of cost isn't even a barrier now, right? So it's really just time. And so as we get back to kind of one of the three things that I was talking about, the fourth is time, is that nobody that I've ever met has an hour of their day where they're sitting around, I wish I had something to do. I'm just going to sit here and do nothing for, like, rarely do people have that, right? Maybe if you're in a layover at an airport or something, but you have to create that time, invest that time, because investing in yourself has dividends. And as a cardiologist, I see it. You can't be awesome in your 70s and 80s, right? Unless you're doing a lot of really great stuff in your 40s and 50s, right? So now's the time to set those habits and continue them, right? Don't just be a January 1st or being in the gym the first week. Make them part of your everyday routine, right? And that's really where I think people get the best outcomes.
I love it. We had an interview with one of the founders of Smart Fit Girls, who's a PhD down in your neck of the woods, actually. She's in Southern California. It's like this 10-week program where they teach middle school girls to lift and they teach the program. It's so cool. And like you can have a chapter near you. Like there's so many ways to do this. But I loved hearing that you were a power lifter. It was like we had such a cool conversation about that the first time we met. I was like, no way.
Well, I know that my voice probably makes me sound like I'm 6 feet, 13 inches tall, but I'm, at 5'5", there's still not a lot of sports that you can play. I grew up in Indiana, so I was a basketball player up until I think probably about fifth or sixth grade, when I kind of stayed here and everybody kind of kept going and going. And I was just like, where did everybody go? And so powerlifting was one of those sports that I just kind of fell into. It evolved from a CrossFit obsession that I had, a brief affair with CrossFit that I had, and just realized that the body mechanics that I had, like, I mean, we're talking about kind of the nuances. So like femur length and tibular length, like the bones of your legs, the length and the this and that. I mean, that all kind of is in the equation of the physics of your ability to hinge and lever and all these things. And so it just kind of worked for me. I remember actually the first time I considered powerlifting was at my buddy's CrossFit gym. And I was paired up with this guy, my friend Bill. He's probably 6'2" or something. And we're doing front squats. And he maxed out. And I just kept going and going and going and going, just adding on weight, adding on weight. And then somebody was like, you should, think about powerlifting. And I had no idea what that was. I'm like, I'm not going to wear a Speedo and walk around and spray tans and all that stuff. That's just not part of my plan. But yeah, it was a great sport. And I'll tell you a story was that we have a lifter here in Southern California who I think was 82 years old, and she was competing. I mean, she was like the only person in her group. And the absolute cutest thing was that she, at the competition, was just trying to bench press the Olympic bar, which is 45 pounds. And I tell you, you would have thought you were at the Super Bowl with how loud everyone was cheering for her to get that bar up. So, I think a lot of people, maybe a plug for powerlifting, but a lot of people think that it's just kind of these big muscle bound people, but it's such an amazingly supportive community, because really you're not competing against anybody else. You're really just competing against gravity. That's how most of us look at it, right? And don't be afraid to resistance train. And you don't have to squat 100 pounds or a million pounds or whatever, but even like rubber bands and resistance, that builds lean muscle mass, which I think is hugely important when we start to talk about body composition, because weight is an imperfect measure of health, right? And I think particularly, I was just interviewed for a news outlet a few days ago about this. Is that we really need to kind of get away from using weight as any sort of marker of anything. And now that we can measure body composition, like lean muscle, adiposity, visceral fat, all these things relatively easily, I think that's something that needs to be focused on a lot more. And again, IFM in the training has this great algorithm that kind of shows like the heavily muscled person, right? Because with BMI as an imperfect measurement, if you're heavily muscled, you're considered obese, right? But how to differentiate between like well muscled, actually overweight, skinny fat, normal, kind of all these things. So I think that's a very important thing to do. But yeah, but seeing like all these like 50 people cheering at the top of their lungs for this woman to bench press an empty bar was just one of those, gives me goosebumps. It's just one of the funnest moments of my life. I think her name was Evelyn, actually, now that I think about it. But
Heck yeah, Evelyn.
if not, it could be.
Yeah, I tell everyone that's what I'm training for. I'm like, I am training so that I stay fit long enough to make it to the like 80 and above group and compete then.
That's like me trying to qualify for the Boston Marathon. I think I have to be 10,000 years old to be in the age group that my marathon time would qualify me. So I'm waiting for that.
Yeah, just keep going. Just keep going.
Just go infinity. Yeah.
I highly recommend powerlifting. We talk about this a lot on the podcast, but like it's a more relaxed sport than I think people realize. Like you walk in a powerlifting gym and people will lift something heavy 3 to 5 times and then they're resting for like a while.
It's like I used to call cardio sets, any set that was more than 3 lifts, right? But when you're prioritizing strength, right, you have to do kinda high weights, low reps, and then you have to give your mitochondria, right, time to recover and to create that ATP so that you can kinda maximize your next lift. And probably of the exercise that you can do, powerlifting is probably great for mitogenesis, I'd guess too, right?
Yeah, I think we who counsel people about metabolic health, I love when we can talk to people about adding muscle versus focusing on losing fat because I think so many people think, well, now I got to get on the treadmill and I got to not eat and I got to starve myself so I can get rid of this fat. And usually it's the opposite. It's about putting in the work at the gym to build muscle, to build bone, shifting what you're eating, usually to consume more protein and fiber and complex carbohydrates than you might have been consuming less highly processed foods. And you just see your body composition change in this way that's really cool and rewarding and feels, I think, so much better than what we were taught to do.
Plus, it just feels awesome to lift heavy stuff. Right? I mean, let's just talk about from an ego standpoint, it just is awesome to be able to just lift 400 pounds and have people look at you in the gym different and stuff. So, yeah, it's fun.
And if you're not there, you can get there. Someone's thinking 400 pounds.
Yeah, I mean, so I maxed out on deadlifts at like 410 or something like that, but that took me about 2 or 3 years to get there. And what I love about it, and we're talking about goals and exercises, I think it's important to have a goal, right? And just an unyielding, like how many times I wanted to stop, but 405, which for those of you who don't lift, that's 4 of those big plates on the side. That was just my goal because for some reason I thought that was awesome and nothing stopped me. Like, I mean, I definitely had days where I did better than others, but you just continue. And it's like with anything, success is inevitable if you put the time and effort in, right? So similarly to metabolic health, and as we talk about maybe kind of body composition shifting and stuff, is that if you do the work, it's going to happen, but you have to do the work, right? You can't pay somebody else to do the reps for you. Like I can't pay someone to exercise for me and expect that I would have the result, right? You have to do the time, and it has to be a priority, right? You have to make it a priority.
It's so true. Well, I want people to know where to find you because I'm sure everyone's fallen in love with you in the last hour and they're thinking, how do I get Dr. B to be my doctor? Tell us about Well 12 and yeah, where folks can get more.
Yeah, so we talked at the top of the hour about this unfortunate kind of discrepancy between clinical practice and how we're supposed to practice, right? Really kind of focusing on those 3 to 6 months of diet and lifestyle changes that honestly most conventional trained physicians and doctors just don't have that skill set. And so I created the Well 12 program. It's a 12-week wellness journey. I'm not super imaginative, so that's where the name comes from, Well 12. But what we do is focus on three factors. So diet, stress, and sleep. You can just optimize those three things. So much gets better. So much improvement happens. But we give that structure, right? I've created this structure, this framework. You're monitored by coaches and you're logging in your foods. Everybody gets this wearable device so that we can kind of track your sleep. I'm a huge fan, of course, as a cardiologist, of heart rate variability. That's a whole other podcast that we can kind of probably create at some point in time. But essentially, that's a balance between that sympathetic, the rev up fight or flight system, and the parasympathetic cool down system. So, where that heart rate variability sits is a metric of how much sympathetic or parasympathetic tone you have. And teaching people, how do you optimize stress? How to use breath work, for instance, to optimize when you can't sleep or if you're stressed out. What are the mindset shifts that we can have? And then, getting back to diet, kind of this kind of cardiometabolic, low inflammatory diet. So reducing the body's burden of inflammation, optimizing cardiometabolic and really mitochondrial health to unlock the body. And the program is now over a year old, and the results have been absolutely amazing, all without tons of supplements and all that stuff, just really teaching people what to do. My MVP, actually just my most valuable player here, just kind of reached out to me earlier in the week. He is now down 130, 140 pounds, something like that, off of 7 medicines. He was on 3 diabetes meds, 3 blood pressure meds, and a cholesterol medicine. And all of his numbers normalized. He did the work, right? I mean, he did the thing, but I mean, he is unrecognizable. In fact, he comes out surfing with me when we're not getting inundated by rains that we are getting right now in Southern California. But I mean, his life has totally changed. Another woman just reached out to me and she said that she was suffering from long COVID, which, as the functional medicine community kind of understands, there's a lot of inflammation and inflammation gone wild, basically, right? And she was getting tested for Alzheimer's dementia and did the program, and we dropped her inflammation. I think her CRP dropped by like 50 or 60%. And now her brain is functioning again. And she can't believe that she was worried that she was getting this diagnosis of Alzheimer's, and thyroid and metabolic, all these things get better without medicines, right? And for as technology forward as I've been for the first half of my career, I think on the back end of things here, I really just want to get things done naturally for folks, right? And look, I'm not saying nobody needs medicines ever, right? I'm not saying that at all. But let's optimize the things that we can optimize, right? And really get people healthy without medicines. And that's again why I feel I'm so in love with functional medicine. So the website is www.well12, that's WELL12.health. So well12.health. And you can pop on there, learn a little bit more, join the newsletter. If you're interested, you schedule a consult with me and I kind of run through exactly what it is. But for all the people I've saved at 2 a.m. with their heart attacks and all the 90-year-old people I was able to put a heart valve in and they're walking out of the hospital the next day, really the most joy I get as a healer has been from this program, because it's not just giving people, better health, but giving them the habits so that that health is going to be sustained, right? And it's just, I get goosebumps when I talk about it because it's just been absolutely amazing. Like in my own family, we did it and it's completely changed my kids' eating patterns. We were on a road trip somewhere, and as we all know, road trip food with little kids, right? It's nothing healthy. And my wife busted out these red bell peppers, and one of my daughters from the back seat kind of was like, "You didn't tell me you had bell peppers. Pass those back here," right? And that would never have been a statement that we would have heard of before. So as you think about the generational impact, as we were talking about before, of exercise, but the generational impact of diet, if I'm eating healthy, I instill those healthy eating habits in my children, then just think about how my grandchildren or great grandchildren are going to benefit, right? Like if you think about the epigenetic modifications that are happening for my children, like the health habits that I'm instilling in them is going to help 3 generations from now, right? Like I will never be alive to see those kids born unless I get to 10,000 years of age and I'm running that Boston Marathon with my 6 hour marathon time. But this is what needs to happen, right? This is what healthcare needs to be, right? Like we need to actually focus on the health part of healthcare and actually giving people the tools to become healthy. And that's not medicines, right? That's let's optimize our diet. Let's optimize our lifestyle. Let's do things that are going to be meaningful, impactful, and sustainable, right? Because what happens if you lose your insurance coverage, for instance, and you can't afford a medicine? You're going to suffer, right? But nobody's ever taking broccoli away. Asparagus ain't going anywhere anytime soon, right? But learning kind of how to eat correctly for yourself, right? Because everyone's a little bit different. And, how do we optimize sleep? How do we optimize stress? And then slowly then once that's kind of set, how do we incorporate movement into our daily exercise and our daily routines, right? So it's just been amazing. I tell people it's almost like the playbook for your body that you never got, but it's remarkable, and I just can't wait to get as many people as I can on this journey to being better humans.
I'm so grateful that you started Well 12 for the world, and I'm also so grateful that you're teaching our practitioners too. So if you are not a clinician, go be Dr. B's patient at Well 12. If you are a clinician, come learn from him in the IFM boot camp. We're going to have some more opportunities for you to learn from him coming up at Rupa soon. Thank you, Dr. B, for everything you're doing to help people heal and thrive.
Hey, thank you for existing. Keep up what you're doing and just continue to be awesome.
Thanks, Dr. B. We will talk to you soon.
All right, take care.